All right, good. Welcome everybody here this evening to our third live stream event for COVID-19, an update for primary care. Before we do start, my name's Scott White, I'm the Communications Manager with the Primary Health Network. We'd just like to acknowledge the traditional owners and custodians of the land that we're meeting on here tonight, the Awabakal people, but also acknowledging those other nations right across our region that we are broadcasting to tonight, and also to welcome any of our Aboriginal brothers and sisters that are joining us tonight. Thank you very much. So tonight, John Bailey is here. He's our Executive Director for Primary Care. John will just give to start off, a quick update on what the Primary Health Network is doing in this space, and then I'll pass over to our colleagues from the local health district who will give a bit of an introductory update on where we are with COVID, and then as in previous live streams, we'll move to the question and answers, which you can continue to provide on Slido. So thanks very much, and over to John.
Thanks, Scott, and I too would like to acknowledge the traditional owners of the land. In terms of what the Primary Health Network's doing and will continue to do in this space, I just wanted to draw your attention to a few things. Each day we're sending out a COVID-19 bulletin to all primary care clinicians in our area. You will have been automatically subscribed into that, but if you haven't seen a copy of it, please check your junk box or your junk email container and check it's not gone in there. If it isn't there, then you can go to our homepage and there's a subscription link which will allow you to be connected in. The other important communication tool and source of truth that we're using and doing on behalf of the state is the Health Pathways site. Can I encourage you and your colleagues to have a look at the Health Pathways site on a regular basis and keep revisiting it, because the information changes quite rapidly. It remains our source of truth for clinical advice. For patients, the patient info site is being updated with clear and concise advice on COVID-19. Respiratory clinics. I know that respiratory clinics are of interest to all of you, and I just wanted to give you a bit of an update on where we're at with those. As you're aware, the Commonwealth have announced 100 respiratory clinics to be located in the community. These are aside from those being run by the local health districts. I want to just reinforce that these are not drive-through screening services, but are in fact aimed at the mild to moderately unwell. There are 5 proposed sites, one on the Central Coast, in and around Erina, one in the New England, in Tamworth, one in the Manning at a site yet to be determined, one on the western side of the lake at a site yet to be determined, and one in the Lower Hunter at Raymond Terrace. Just wanted to talk a little bit now about what we're doing in relation to aged care. As we know, the elderly are one of the most vulnerable groups in relation to this particular virus. We've established a working group in collaboration with the LHDs to plan and assist residential aged care facilities in the preparation for the inevitable infections that they will receive. We're working on infection control training to reinforce the existing practices and bring people's skills up to speed. We're looking at workforce management and secondary triage for unwell residents, and we're engaging a range of clinical staff to assist us, support us, and provide advice on that, including a well-respected geriatrician, GPs, an ED physician, CNCs, CNSs, and others. That applies to both local health districts. We're also looking at the rapid deployment of a capacity measuring application, which will give us early insights into the capacity of residential aged care facilities through this particular event, and hopefully be available in the future for influenza seasons and for other situations where we need it. PPE. I know that each of you are concerned about your PPE. Can I just stress to you that PPE is in national short supply and in fact in international short supply. Production services are being scaled up to deliver more PPE, and as they come online, we expect this to improve. However, it will take some time, and we need to conserve and appropriately use the PPE we have. We've been advised today that hand sanitiser is available for purchase in bulk quantity to primary care locations, including residential aged care facilities and specialists. And there'll be an how to order link in our bulletin tomorrow. So for no other reason, subscribe to the bulletin tomorrow to find out how you can order sanitiser. On Wednesday of this week, we'll be meeting with the GP chairs of the clinical councils to discuss this and current areas of external communication. We'll also be looking at how we can plan and manage the workforce over the next interim period and to get us through this particular crisis. We'll be working with Rural Doctors Network to look at a statewide approach and a coordinated approach. Can I urge you once again to go to Pathways as your source of truth for information from the PHN. Thank you.
Terrific. Thanks, John. Let's just get myself mic'd and check that that sound volume's all right. So I'm Tony Merritt. If you've been on one of these previous two, you've met both, all of myself, Kat Taylor, both from the Public Health Unit, Public Health Physicians, and John Ferguson, ID Consultant and Infection Prevention and Control Lead. So look, great to be with you again. Very different to last time, in a small room here with a very small crowd, doing exactly what we're asking everybody to do. So there's no GPs in the audience. Must be a little bit like playing at the MCG on the weekend, I suspect. So it's a quiet crowd, I assure you. Great to have you with me. I know there's lots of you there. We've got a shortened presentation, as we have in previous times, not any duplication, I don't think, and then we'll really concentrate on your questions. So thanks for bearing with us. As always, Slido is on offer. Lots of you have sent questions in ahead of time. Please, if you haven't already, make sure you've got Slido on your device, and the event code is PHN3, and we thrive on your questions. Please, we'll try and get to as many as we possibly can. All right, little snapshot on what's happening globally. Some of these I put in last night, some this morning. Most of them are out of date already, of course. Things moving really quickly. The slide in the background there is the one we presented just under 2 weeks ago. 113,000 cases, 4,000 deaths, and clearly we've moved dramatically in that time, and we've seen countries all across the planet start to experience this pandemic. You can see Africa starting to light up now, as is South America. So things have moved really quickly, and we won't spend a lot of time on the international epi, but just a couple of kind of indications of just what's happening and hopefully some important differences. So here is a cumulative count of cases for 4 countries. So in blue there is Italy, and we see Italy in the headlines regularly with the strife that they're in. USA on a similar trajectory, but delayed there in the brown there. Important story with Korea, see flattening out, and hopefully some lessons for us about bringing things under control. And you might at first glance be reassured by Australia at the bottom there, which looks pretty flat on this scale. That's 40,000 cases at the top. But unfortunately, this is what Australia's going through now, and this is the reality of exponential growth, and our turn has come. And you can see the cumulative count over recent days has taken us over 1,000 cases. And it is exponential at the moment. It's one of the reasons it's so critical that we all act. Doubling time of about 3.5 days. So if we do nothing with that doubling time, we get to over 60,000 cases in about 3 weeks' time. And Australia's total ICU bed capacity would be required for something in the order of 45,000 community cases in Australia. So clearly that's not a route that we want to travel. Australia's heading on a really similar trajectory as many countries in the past. So this chart, many of you will have seen, it's reset for countries being at the 100 case level. So we are not confused by that that x-axis, the timeline. And Australia's travelling on a very similar trajectory as many others. You can see there's a few breakouts there in blue. So Hong Kong, Singapore, absolute standouts, and I mentioned South Korea before. Clearly we need to learn from those countries and look at what we need to do in Australia with urgency. Locally, in Hunter, New England, there's a chart of cases by report date. Again, out of date, so the current tally reported tonight for Hunter, New England is 47 cases. Again, we're doubling our case count every 3.5 days or so. And it's critical to understand that the cases that are reported are necessarily a snapshot of what was happening about at least 4 days ago, by the time somebody who's already sick gets through the system, gets a sample collected and it gets to us. That was 4 days ago. So the people who are sick right now are not going to appear in our case count for another 4 days or so. So it's at least twice that count. And you'll be interested to see just a little bit of local epi there. Lots of people coming from overseas. Over half our cases have come in from international destinations. Some, about 20% linked to confirmed cases. But importantly, that group there of 4 people, somewhere between 10 and 15%, where the source of their infection is not known. And we're throwing massive resources at this to understand what's happening locally. And that is, that's local transmission. That's obviously something that's acutely important for us all. Right-ho, current recommendations. Well, I had to slip this slide in. Hopefully many of you saw this last week with Skywriter in Sydney kindly reminding us what we all need to be doing in great style. Public health action, a lot of this is exactly as we've said in the past, critical that we continue finding cases, and that means lots of testing. And then when we do, really rapidly isolating those people to stop transmission, finding their close contacts at risk of already being infected, quarantining them so they can't infect others, and repeating. So even as things ramp up enormously over the weeks ahead, this is still a really critical part of the response, and so we all have an important role in terms of finding cases and making sure that can be actioned rapidly. Clearly, very much in the news now is this critical additional element of social or physical distancing and the measures that we need to take as a community to really slow the spread of COVID in the community. So a couple of slides on that. Hopefully some of you will have seen this Ferguson report. I assume no relation, John? So from the Imperial College, it's not a long report. I recommend it to you if you're interested in seeing some of these issues play out. And a couple of important takeaway measures. This is said to have had a really significant impact on the path that the UK has taken in their control. It's a busy slide, I guess, but these different curves here are modelled estimates of what would happen in a range of different intervention scenarios. So the black curve there is hands off. That's letting COVID run its course. And the red line at the bottom is intensive care unit bed capacity for all of the United Kingdom. And so very rapidly that's exceeded, and at the peak of the do-nothing scenario, ICU demand is about 30 times capacity. Those other curves are a range of interventions. If we just go to the bottom one, the one that looks most promising, that's a combination of isolating cases, as we've said is going to be critical, home quarantining, close contacts, and just limited social distancing. This is just asking those over 70 to shelter at home and keep them out of harm's way. And that has a really important impact. You'd certainly see that the curve's been flattened there, to use the jargon that we're now hearing so much of. But even with that combination of things, at the worst stage of that, ICU capacity is exceeded by 8 times. So this is that's a problematic approach and will be unacceptable to many of us. And that's exactly the reason we've seen such dramatic announcements in Australia in the last couple of days, and at this concept of going really hard early so that we control the initial spread, slow the initial spread, and that buys us time. In this chart, similarly from this report, the black curve is unchanged. That's the do-nothing approach. But a really intensive package of interventions modelled there in the green for the period of 3 or 4 months. Keeps things under control for an extended period and gives us time to do a range of other important things. There's not going to be a vaccine in 4 months' time, but we'll be closer. We can expand the healthcare capacity, both in terms of workforce and bed capacity, ICU and ventilator capacity. We can expand lab and PPE supplies. So that's the rationale, but that takes extensive general social distancing measures in addition to the isolation and quarantine. So that's the logic, and many of you will have seen this article in Medium. It's been a couple that are, I think, really lovely explorations of the data, and I like this idea, this phrase that Thomas has used of the hammer and the dance, and it's the hammer, hopefully, we're implementing right now, which will help bring slow transmission and bring things under control. And then over an extended period of time, there'll be the dance when we ease controls off. Cases may increase and we'll titrate the response to a level that we can all work with. So that's a little bit on the background in terms of social distancing. We're going to see a lot more of that evolve over the next couple of days, and clearly a lot for us to get our heads around. That's going to be critical to bringing this under control, but as I stress, finding cases and isolating and quarantining their context is still going to be really central business to this working. It's the package of all those intervention measures that gives us our very best chance of slowing spread. So who to quarantine? These are people that need to be out of circulation, quarantined at home for 14 days from their last exposure. It's a group that it's just changed modestly since we last spoke. So all return travellers from overseas, so all countries, trigger this quarantine. Any close contacts, and it has to be close, and Kat will explore what the criteria are for close contacts in a little while. They need to be isolated at home strictly for 14 days. And healthcare workers, of course, get caught up in that first category. All healthcare workers, regardless of when they got back, need to be quarantined at home and not at work for 14 days after the time they arrive back. Now, importantly, we're talking about people who are not sick. These are all people who are doing us an enormous favour by staying home and out of circulation. Incredible burden, but it's just so important that this group are out of circulation so that if they do develop symptoms, they're not putting others of us at risk. So they're really heroes, and they're really helping us bring this, giving us a chance of bringing this under control. We need to make sure we really acknowledge that whenever we're dealing with this group. But importantly, there's no logic in testing people who don't have symptoms, except in research studies. So this group don't need testing, they just need to stay home for the 14 days. If they do develop symptoms, of course, that triggers immediate assessment in a safe way. Okay, that's quarantine, going to be critical, it's going to stay critical. In terms of testing and isolating, and clearly one of the takeaways has been for a couple of weeks now, if you test somebody for COVID, it's just so important that they are also then isolated until we get that result back. So those two things almost always just go really strictly together. So who to test and isolate any suspected cases. We'll go through the testing criteria again in a minute, and any healthcare workers who have both fever and an acute respiratory infection. Keep those people isolated until we've got their results. Fantastic. So lots of testing, isolation, quarantine, testing criteria, and then I think I'm handing over at the end of this. Is that right? And so, we could do that right now. I'll just finish that off. So testing criteria, I acknowledge that this is a moving feast, and that is just absolutely inevitable. These are the New South Wales testing criteria as they stand tonight, and it will be different again almost certainly next week, certainly in a couple of weeks' time. So bear with us. We appreciate that there have been many changes, and that's been inevitable as this pandemic's evolved. So who to test? The key group remain travellers from overseas, plenty of the returnees who are still in their incubation periods and developing symptoms, a really important group. Similarly, close contacts of people with confirmed COVID infection. And as I said, healthcare workers who have both respiratory symptoms and fever, really critical that all those groups are tested. They should be absolutely highest on your radar. In addition, we look at people who are admitted to hospital, inpatients with acute respiratory infection triggers, and then expanding interest in people in high-risk settings. We'll talk about aged care in a moment. So really important that we think about COVID in aged care respiratory outbreaks. And also in the context of known settings, we might talk about that more in question time, some of the transmission settings that we're aware of around New South Wales and the country, for example, and in those contexts where there's additional epidemiological information, really important that we test as well, as it is in highly vulnerable Aboriginal, rural and remote communities. So Kat, I think at that stage I've already cribbed one of your slides, I apologise, and I'll hand that to you.
Okay. Oops. Okay, how are we for sound? Thank you. Just waiting to see that our tech is running okay. And you might hear that I'm myself recovering from the tail end of a cold, so I will tell you about my journey as a healthcare worker with acute respiratory symptoms if time permits. But certainly just following on from what Tony was saying, there's obviously testing criteria, there are also quarantine criteria, and one thing that we'd all be interested to know in general practice is how to, I suppose, handle and triage these patients before they come to the practice. And so all credit to the Health Pathways team. They've got really dedicated members that are on this almost 24/7 it seems. But they've developed quite a nice triaging tool, and certainly this will change over time. But I suppose the first decision point is, are these patients symptomatic or not symptomatic? If they're well, so not symptomatic, then there's a few other screening criteria in terms of whether they meet any of those quarantine requirements. And if they're unwell, then there's currently a risk assessment for whether they fit the criteria for being suspected cases themselves or whether they're in a high priority group, so for example, healthcare workers. So not that we think that these groups are necessarily at higher risk of disease themselves, but just if they do have COVID-19, we want to know about it sooner than later. So a time is coming very soon when probably the box that you can see on the right-hand side of, as you're looking at, left-hand side of the screen as you're looking at it, will probably change, and we'll just go to kind of the screening for acute respiratory and fever, but more to come on that later. So what are the options if you do want to get somebody tested? Obviously, we're aware of a number of GP practices that have set up great systems for collecting the specimens in-house, and we've talked through a few case scenarios of where that's happened and where really great infection control practices have been used so that patients, don't come through communal waiting areas, that they go straight to isolation rooms with masks on, that the consultation's very brief because all of the history taking's been done on the phone. And so subsequently, even when people have tested positive in those scenarios, there have been no contacts associated with that GP practice. So that's certainly a legitimate option if your practice is well enough, well set up to do that, and if you have the adequate personal protective equipment. The second option is private pathology collection centres, and we understand more of them are coming online with each week, and there's a list of those that is being maintained on Health Pathways. Also expanding fairly rapidly the COVID testing centres, or CTCs as you might have heard them referred to. The first being the John Hunter, which was operational last time we spoke, but since then one at the Calvary Mater, Maitland and also Belmont is offering a service which I believe is drive-through, Tony.
Please dial ahead.
Right, please dial ahead.
Swab, don't get out of your car.
Yes, yes. So these are all very legitimate options for people in the community with mild symptoms who fulfil the testing criteria. And I suppose that's another asterisk that we can tail off into maybe during the discussion. But currently, patients that don't meet the testing criteria outlined before may be turned away from the CTCs. So we can talk about that in more detail later. But for people who are seriously unwell, so people who are coughing a lot or have symptoms suggestive of community-acquired pneumonia, have shortness of breath, etc., we would be recommending that you just refer them directly to the emergency department. Another option which we haven't put on there is the Health Direct info line, so that can also be another mechanism for handling some patients that are symptomatic but maybe only mildly symptomatic, so triaging through that. And as John flagged earlier, we're looking forward to the imminent opening of some PHN-led collection centres in the community locations described before. So testing options are expanding. Obviously there is some limitations in terms of the amount of reagents and swabs and things, but for the time being we would encourage GPs to just continue testing people as they see appropriate. Right, so what testing is recommended? In view of the in view of potential shortages and also in terms of maintaining good custodianship of the resources that we do have, the testing requirements have recently been changed. So now the recommendation is to only collect one swab. So previously it was 2 swabs. However, now that's dropped back to a single swab. Obviously, if your test kit has 2 swabs with 2 transport media, then you may not be able to 2 swabs and 1 transport medium, then you're not going to be able to reuse those swabs necessarily. But all you need is 1 swab, and that should be of combined sites from the oropharyngeal location and also nasopharyngeal, or nasal, I believe. So, deep nasal, yes. Yeah, deep nasal and an oropharyngeal throat swab. Again, the requesting has changed slightly. So previously we were recommending that all patients that are tested for COVID-19 also receive a respiratory multiplex. John, you might be able to speak to this, but I understand the reagents that are used are the same for both the multiplex and the COVID-19, and that is a bit of a rate limiting step. And so for that reason, we're suggesting that patients only receive COVID-19 testing. One exception, or a couple of exceptions, may be in settings such as healthcare workers, where having an alternate diagnosis might be quite useful, or also aged care facility outbreaks, where it might be quite valuable, to know. Basically, if it's going to change your management, if you are going to potentially start Tamiflu or something like that, based on a positive flu result, then do request additional pathogens. But if it's just looking for COVID-19, then just swab for COVID-19. Okay, we're going to spend a little bit of time talking about the management of confirmed cases and outbreaks, because this is sort of what we're coming into now. This is what's going to be coming through your practice now. And just highlighting the higher level goals of management, obviously limiting forward transmission, and that's where the public health unit is very involved, very interested. We'll be on the phone to you quite quickly with all confirmed cases. So limiting forward transmission, that was all the content that Tony spoke to you about, quarantining and isolation. Also supportive treatment. So John can speak to this a little later, but still no developments in terms of the practical space of what is being used for treatment. There are some clinical trials going on, which I think John can talk to later. But currently just supportive treatment. And also, and this is quite crucial in the general practice setting, vigilance for and treatment of complications. So increasingly, we're going to see large numbers of mild cases being managed in community isolation. So people being isolated at home, but being called every day to check on their wellness. And there is the potential for people, after maybe a week or, 10 days of a mild illness to then deteriorate. So really monitoring for deterioration and arranging appropriate care if that's needed. So that's the state of play at the moment. I thought I'd dwell a little bit on this process for home management of mild cases. This is something which 2 weeks ago was not being considered, and then I think the floodgates have somewhat opened since then as the case numbers have risen substantially. And a lot of these cases, so we know that 80% of people will experience quite a mild illness. So it is appropriate for these people to be managed at home, not to be in hospitals exposing other patients and healthcare workers. But for these people, obviously, they get read the Riot Act about strictly remaining at home, other than for seeking medical care until they've been released officially from isolation, which is currently a decision that's taken in consultation with public health and or the clinicians that are managing at the hospital. As I highlighted earlier, currently a process is in place of daily follow-up of these people, and that's either done through the clinicians managing through the hospital. There is a process for potentially hospital in the home coming online quite shortly as well, or the public health unit for people that are quite well are making calls to these cases daily. Really critical at a practical level for these people that they need to separate themselves from others. So an ideal scenario would be if people in their house could move out altogether and just, come and bring these people their essential goods and services. But that may not be practical, and so in terms of what we recommend, at a bare minimum, having a separate bedroom and bathroom, if possible, would be ideal, and keeping a surgical mask on the case, and also the carer when those people are in the same space, noting that the people that are likely to be the carer, the household contacts, are also likely to be close contacts and needing to be under self-isolation themselves for quarantine purposes. There's a recommendation for increased cleaning of surfaces. I think we spoke to this last time. And I've just mentioned about the carer. And the release from isolation criteria have recently changed as well. So we can speak to that on this slide. So release from isolation for confirmed cases. So this is, as I said, for confirmed cases. This is not for healthcare workers or people undergoing quarantine for any other reason. So those people need to see out the full 14 days irrespective of test results. So this is people that have actually had COVID and we're wondering when do they become non-infectious and can go back into circulation in the community. So the first category of people is confirmed cases who've had a mild illness and didn't require hospitalisation at all. These guidelines, I think released on, was it Saturday? Yep, over the weekend, say that the case can be released from isolation if they meet all of the following criteria. So the first thing is at least 10 days since the onset of their symptoms. And then they need to have also had resolution of all symptoms of the acute illness for the previous 72 hours. So whichever is longer, obviously. The second category is people who've had more severe illness and been hospitalised for the initial component. Some of these people are getting cleared within the hospital process through the 2 negative PCR test, which is happening 24 hours apart in that inpatient setting. But if they're discharged before that happens to home isolation, then it needs to be 10 days from the date of their discharge. So 10 days from the date of their discharge and also free from all symptoms for the previous 72 hours. So I won't dwell on that. The guidelines are there on the Commonwealth website, the series of national guidelines for COVID, and also linked on the health pathways. But that's the lay of the land currently. Another category is releasing people that are in an aged care facility or a healthcare worker setting. And there are slightly more stringent criteria for these people just because of the potential consequences of, if somebody were still infectious in that setting.
And particularly for healthcare workers.
Particularly for healthcare workers, absolutely. And so these were the criteria that we may have been previously familiar with. But essentially someone has to meet all of these 4 criteria. So afebrile for 48 hours, the acute illness resolved for the past 24 hours, at least 7 days since the onset of symptoms, and then they also need to undergo PCR testing. So 2 consecutive respiratory specimens, at least 24 hours apart, and once that acute illness has resolved for more than 24 hours. Yes, there's a lot there, but it is all on the guideline. I think, so this was just, I suppose, a lesson for why we really do want to keep this out of our aged care facilities. Some sobering lessons from King County in Washington State. And so you can see huge attack rates here in residents of 62%, so 81 out of 130 residents affected. Very high hospitalisation rates in this vulnerable population, and then a very high mortality rate as well. And staff were, well, for want of a better word, not immune. So there was also a high attack rate in staff. So the population in general is completely naive to this virus. And so we were seeing high attack rates in staff and also visitors. So it's not just about the residents, it's not just about workers, it's about, you know, all the ancillary staff, it's about all visitors as well. And we'll speak to some of the recommendations in aged care facilities on this slide. So out of this MMWR report, there were a number of recommended prevention measures advocated for by Washington State. So certainly screening and restrictions of visitors and non-essential personnel, noting my comments earlier about, you know, this is really a setting that's affected. Active screening of healthcare personnel, and I would also recommend this, you know, in your own practices, that you really try and be actively monitoring people, potentially even every day, having a check-in for people with symptoms, and really going hard on excluding anyone who has any symptoms. Very heightened surveillance, so symptom monitoring of residents, and then social distancing, which we've spoken about, and addressing some of the local PPE shortages. So these are all things that we're probably going to come up against in the coming weeks. There is current guidance available in terms of managing outbreaks of COVID in aged care facilities in Australia. So this is CDNA, the Communicable Diseases Network of Australia, have prepared an interim guideline on that. And that is probably going to be under review as well. I understand there's also an aged care outbreak working group that's been convened by the PHN. So there's a lot of work happening in this space. But in terms of doing our part as GPs, certainly, you know, heightened vigilance and screening of residents. Okay, so sorry to harp on about this, but we just wanted to focus in on COVID-19 in healthcare workers, because we have been we have noticed some cases in healthcare workers who, you know, may not have had any exposure history necessarily, or, you know, might have had atypical symptoms, have gotten tested and then thought it was okay to go back to work whilst awaiting the results of that test. So emphasising that the screening criteria in healthcare workers are relaxed. So it's testing anyone with fever and respiratory symptoms, so an influenza-like illness. But you can also consider testing people who have isolated fever or respiratory symptoms on a case-by-case basis, noting that we really want to pick up disease in these people if they have it. As I said before, if tested, maintaining really strict quarantine whilst awaiting test results. So I was working from home for all of last week while I awaited my test results from the John Hunter CTC. And hopefully that turnaround time is improving now that Pathology North is now actually testing locally in Newcastle. So that's great news for us. And then the third thing I wanted to mention is in terms of how we categorise close contact with a COVID-19 case in a healthcare setting. So that's, the risk assessment is basically defined as more than 15 minutes face-to-face, and that's cumulative minutes without any PPE, or more than 2 hours without PPE in the same kind of office type space or waiting room type space. And unfortunately, the implication for people that are defined or assessed as close contacts is that they do need to go into quarantine for 14 days. Okay, so I think I'm handing over to John for a word on infection control. Can you see the slides, John?
Yes, thanks, Kat. So just a word about the testing. So currently the inpatient and ED specimens are going to be tested locally. The volume's such that they're still going down to Sydney. The fever clinics are still sending specimens to Sydney, which means a turnaround time of 3 to 4 days. Same day if tested locally, largely. So I think the infection control recommendations haven't changed since last time. So basically with a case, we're managing a case or a suspected case, we're expecting standard contact and droplet precautions. So that means a mask, goggles or wraparound eyewear, gloves and a gown technically. We do have shortages of gowns, and so There are ways of clinical care that don't involve you contaminating your clothing if you're careful. If you're bare below the elbows, I would sense that it's low risk for you not to go without a gown if PPE is short. I think the most essential things are the eye protection and the mask and the hand hygiene, certainly. We do need to worry about hygiene of surfaces because that's where hands will pick up virus. And we know that the virus, from recent data, survives probably up to 4 days on hard surfaces, a bit different, differing by the type of surface. And then, of course, airborne precautions elsewhere where we've got a severely unwell patient or there's intubation or other potential aerosolising procedures. So surgical masks, there are 3 levels of surgical mask. I think they're all labelled as such. You can see the level 1, 2 and 3. Level 1 are really only used by patients with symptoms to confine their droplets. Level 2 and 3 could be used by healthcare workers. They vary in their moisture penetration, level 3 being the highest. Level 3 masks are in very short supply. There's none in the state warehouse. They're all confined to theatre use currently. Level 2 is what you probably are used to. That's the level 2 mask there pictured with the loops going around the ears. So these are not designed for reuse. Even if you take them off, don't dry them and then reapply them. The danger there is that they're contaminated and then you may contaminate yourself as you put them on. We shouldn't touch the front of the mask. And we can wear these up to maximum of 60 minutes really if with a normal person because they get moist and that moisture impedes their barrier function. So I think we've talked about the other things. It's interesting, since we last met I mentioned that there was a randomised trial comparing N95 respirators with surgical masks in outpatient influenza settings, so a very large trial from America. The Chinese have since come up with a Cochrane review looking at, I think, 6 randomised trials, albeit that the American one was by far the largest one of those. And the finding was similarity between acquisition of influenza. Most of these trials have looked at influenza, some looked at other respiratory viruses as well. So it's not exactly not exactly the same virus, but I guess the reassuring thing to me is that the extensive Chinese investigation by WHO failed to show that aerosolising procedures were part of any of the transmission chains that the Chinese investigated. And we know that the Chinese investigated more than 1,000 transmission chains that very assiduously went after every case and their contacts. So that gives us assurance that aerosolisation has not been a major factor. We've got some local data emerging from an exposure event within Hunter, New England, which also is telling us some similar things. So I think we should have trust in just routine droplet precautions, particularly if we're very careful with removal of the PPE and careful with our hand hygiene. I think the additional value of gloves and gown are arguable. We don't have any direct evidence that they're key. Obviously you'd be wearing gloves as part of standard precautions in any case if you're going to encounter blood or body substances. So what are we doing about PPE conservation? There's a lot of work looking for alternative sources. People are offering to 3D print N95 masks. I saw that offered today. I had a neurologist come to me with a pair of underpants that he'd cut in a particular way so that fresh from Woolworths. And there was a serious inventor who demonstrated it to me, the double layer of cotton acting as a barrier there, and it looked pretty good on the head, particularly if you had the right brand of underpant.
You've taken us to a whole new place here.
So we may have to get dark and devious that way, but I think in essence we need to conserve what we have. The N95 masks, if you are using them, are actually able to be used for extended periods of time without impeding their efficacy, not like the surgical masks. So you could potentially use an N95 continuously over a shift. It will get to be quite uncomfortable though. Again, if taken off at the end before a tea break or something, it should be discarded and clean your hands. I wouldn't be trying to dry them out and put them on again because of the danger of contamination. I think gowns are in short supply, so we're looking to linen gowns, going back to linen gowns and laundering them at high temperature. That might get us out of that problem. Gloves are not in short supply. Alcohol hand rub has also been an issue, despite the manufacturers expanding production. I guess my secret hope is that Wuhan will start exporting masks again. That's one of the central places where masks are made, and the Chinese no longer need as many. Indeed, they're helping out the Italians with their outbreak response.
And a question on the fly, John, would you have any anxiety about using masks coming out of Wuhan?
Certainly
we get
not.
questions about whether it's safe to use masks that we're importing.
Oh, well, the factories producing them there are ISO accredited for sure. They're high quality masks, and I think the Chinese have shown that they work through the
Get to us too.
True. Part of our problem in the hospital is the antiseptic wipes we use for general use. The Clinell wipes are made in Britain, so that source has dried up. The alcohol and the other brand of wipes we use is made in the USA. So we need to stand on our own feet, I think, and come up with our own solutions to these things. I think that brings us to the case study, Kat.
Oh.
I should have brought the underpants with me.
Thank you, John. Yes, and we are getting some interesting live commentary on our sharing of this microphone.
Pardon,
So thank you for that commentary. Oh, can we use that mic? Oh, okay, excellent. Just while you have the floor, John, I might just ask a couple of the Slido questions that have come through related to PPE. There was a question sort of around extended use and duration of use of masks. Are there things that can be used for a longer time, for example, and not change between patients?
Yes, so certainly you don't need to be changing your eyewear necessarily, and as I've mentioned, the P2 mask and the N95 mask can be worn for some hours. Surgical mask we say up to an hour, but if it's significantly moist, then change it. So you could potentially be wearing a mask and goggles, eyewear across multiple patients. If you're wearing a gown, again, the gown can be served across multiple patients if we take care not to get the gown contaminated, or if it's become grossly contaminated, of course, do something then. And then you've got the job of changing gloves, so removing gloves, hand hygiene, new gloves for the next patient or the next procedure.
And I think that also feeds into another question about, is it necessary to be just routinely consulting in a mask, apron and gloves?
I don't think we've come to that. No, I think that possibly gives the wrong message to people that we should just be wearing masks even though we're well and we're not being exposed. I mean, we should be relying on other social distancing. Even within practice, you can practice distancing from patients who quite adequately, I think, in the office setting, and wearing a mask unnecessarily will impede communication, I'm sure.
There are some questions coming through, related to your underpants inventor, questions about the use of homemade masks. My understanding is, I think there have been a couple of studies that have shown that cloth masks are not as effective, but...
Yes, look, it's really, if we have nothing else, I think they would be valuable, perhaps particularly for a symptomatic person who is having to go outside or so on. He is preparing a YouTube video which we'll share, so you'll get the full story tomorrow, I'm sure.
A picture tells 1,000 words, I'm
yes.
sure. Okay, and I think that's about it for PPE, but we will come back with some more questions
True,
about
yes.
infectious diseases generally. Yes, there was one about using antivirals as prophylaxis.
Yeah, so this is, I think there's absolutely no data on this. It's been a long bow drawn from that initial evidence with chloroquine or hydroxychloroquine. You'll know that that's an anti-malarial that changes the endosome pH, and it has a non-specific antiviral effect with viruses that require an endosome for to fuse to an endosome to enter the cell. And that data is from, there have been some initial treatment trials that indicate viral load declined at a more rapid rate in those patients given chloroquine than not. But it's a very long bow to then extend that to a prophylaxis situation where the pathogenesis is different. Hydroxychloroquine, which is the chloroquine equivalent we've got in Australia, is in short supply. It's used a lot in rheumatoid arthritis and in other autoimmune conditions. So there's many patients that rely on that drug anyway. So it's important that we use it responsibly. And I think the bottom line is there is a randomised trial being set up by the ACID, the Australasian Society of Infectious Diseases. So the ethics for that, I think, went in today. It's going to be fast-tracked. So that's going to be a 4-arm trial, placebo-controlled trial with either placebo, chloroquine, hydroxychloroquine, or lopinavir, rotenavir, Kaletra, or both of them together. I think, so that'll start recruiting before long in around 20 hospitals across Australia.
Thanks, John. All right, we'll come back to some of that more in-depth discussion shortly, but we thought that it would be good to share with the audience a couple of case studies based on recent scenarios that we've encountered through confirmed cases at the Public Health Unit. Oh, thank you. Thanks. So the first case study, this was a young adult patient who attends uni. Interestingly, this patient had not had any travel history, but they had attended a mass gathering in Sydney a week prior to onset of illness. They had the onset of a cough. It was fairly non-specific, and it was even questioned, whether they were just tired from social activities of the previous week. But so a dry cough, a bit of tightness in the chest, and then subsequently they were still feeling well enough that they were going about all their normal business in the community, and even went to their regular GP to have some sutures removed for previous skin lesion excision. This was a very brief appointment. And then on the 12th of the 3rd, the symptoms escalated substantially. They developed a productive cough, and then got the full suite of lethargy, headache, myalgia, and some intermittent sort of pleuritic type chest pain. And they tried to manage it at home for a while. Again, they were not really thinking about COVID-19 given the lack of exposure history. But on the 17th, they did seek medical care, and the GP had great systems in place to be phone triaging people at the time of booking appointments. And subsequent to that process, they received a phone consult, which was done under a telehealth item number. So the GP felt that it was not appropriate for this person to come in, but was quite astute and thought, on the basis of the mass gathering in Sydney and various sort of twitterings about, escalating community transmission in certain areas of Australia, recommended to test. And so this request was done through the private pathology collector. And my understanding is that the private path centres are still fulfilling requests. So even if somebody doesn't meet the testing criteria, if a doctor has requested COVID-19 testing, then people can get testing through private collection centres. However, one caveat is that they're quite busy. They are requiring people to book appointments. And so this person unfortunately experienced a 2-day delay in being able to get an appointment to get tested. So, maybe another thought from this is, if people are in any way set up to be able to collect specimens in their practices, then that would really help with the patient journey and with getting people results and identified and isolated quicker. Just sort of putting that there. So this person did eventually get swabbed on the 20th, and lo and behold, they came back with COVID-19 on the 22nd. And so in terms of their total infectious period, really from the 8th until the 22nd that they were sort of walking around. I mean, they were feeling quite unwell probably for the last 5 or so days and staying fairly isolated. But so there were a lot of contacts associated with this person, a lot of follow-up required. And obviously it does raise questions in terms of, this person did not meet the testing criteria that we currently have, which we think are soon to change. But just really recommending you to, go on your clinical discretion, and if you feel that a person should be tested, then don't hesitate to arrange that. And we're talking about symptomatic people. We're not talking about worried well people saying I need a test. But yeah, I think the case illustrates that quite nicely. Coming back to the exposure that happened for the GP on the 11th, so this was the brief appointment when the person came back to have sutures removed. This actually was during the person's infectious period. So a risk assessment was undertaken in consultation with the public health unit. And fortunately for this practice, it was determined that was a brief consult. The whole encounter, including waiting time, took 10 minutes. And so for that reason, even though no PPE was used, the GP was classified as a casual contact and did not need to quarantine themselves for 14 days. So that was sort of how that case study panned out. Tony, did you have any other comments on that one?
No, I guess it just points, Kat, as you're saying, to the reality that we've seen the epidemiology change, over the last 4 weeks, and that's going to continue to be the case. When we meet again, that proportion of local transmission will presumably be higher again, and so it does call for astute judgment about being suspicious. I guess it points to our growing understanding of the kind of events which are potentially a risk for transmission, and I think the wedding event we've heard about in Sydney is a good example, with people in really close proximity for an extended period of time. We know there's been transmission at that church service in Sydney again, significant numbers of people close together. And they're the kind of transmission events that we're seeing, not brief casual contact. So some reassurance that we're targeting the right kind of people to have quarantine, the people most at risk of developing infection and potentially being infectious to others. Yep.
I think going back to one of your earlier slides, Tony, and the numbers may have changed since yesterday, but there were maybe 4 that were of unknown source. Is that right?
Yeah, in that kind of 10 to 15% range, and that's about what is being seen right across New South Wales. We know our data well, and we've looked really hard. Can't really speak to the data elsewhere, but that's the kind of proportion.
And those 4 were for about a week ago, more than a week ago, I think. All the recent cases have been had explanations.
Well, and we can thank the cruise ships for a great proportion of those, unfortunately, because there's been a small, there's been a wave of cases over the last couple of days, and a substantial number have come from cruise ship exposures. Yep.
So guys, did this case have other close contacts in the household, or?
Yes, many. Yeah. So this was a scenario of several share houses and sleepovers and the kind of lifestyle of people in this demographic, I suppose. And all sort of between Sydney and Newcastle.
Which points again, I might just take the chance to say again, we do owe these people an enormous debt of gratitude, because I don't know the number here, but close contacts for cases we've seen in recent times number between, it might be just a partner, or it might be, certainly it's not been uncommon for us to have 20 close contacts. And every single one of those people we're asking to go into home quarantine for a period of 14 days. So that's a massive impact. Some people in Hunter, New England have been through that and come out, and we are just enormously appreciative of the efforts that people go to make that work. So we need to make sure we take the chance to thank them when we come across them. It's really big.
And could I ask, in China, I think the household transmission was up to 10%
Yes.
of individuals. What's been the local data on proportion of household contacts?
Yeah, it's a great question. I don't think we've got enough time to look at that accurately. We will. We've got great local epidemiology.
Is it high or low?
I've been looking at it at a kind of anecdotal level, and so certainly we need to ask that question, I guess, at the end of the 14-day period. So I know for the people who've come out, I've had a smile, and it's been lovely to see people come through that, household people come through that without becoming infected. And I think the China experience was around the 5 to 10% of household members. So clearly household transmission with that close proximity important, but it wasn't inevitable, and that's something we're reinforcing to local people.
And I guess as we do more and more home care, we're going to get more of an idea as well of whether the carers get infected.
Yeah. And of course the people who are at home are the ones with the milder symptoms. The vast majority of cases in Hunter, New England are being managed perfectly safely at home in people with mild symptoms. That's no guarantee of low transmissibility and viral load, but for some really incredibly mild symptoms and presumably less of a risk. Great.
And I think just picking up on your point, Tony, we have had some really great news stories as well in terms of close contacts who have been undergoing their strict quarantine, have subsequently, unfortunately, turned into cases themselves, but have had no contacts themselves because they've been so diligent about maintaining isolation. So that work is really effective.
Yep. Yeah, really, there's a great image just doing the rounds the last couple of days of, it's getting your head around exponential growth. It's a challenge, isn't it? And I think for a while when we were doubling every 3 days, but it's going from 2 cases to 4 cases, you kind of live with that. The absolute numbers are low, but now when we're sitting around that 47 case, then doubling to 100, it's really substantial. So these particular kind of case stories where somebody's great effort to stay home, not infect the next, on average without intervention, 2.5 other people, just has a profound impact a couple of generations down. Great point.
Now, Tony, I'll just pick up on, this relates to a question that was asked on Slido about 2 return travellers in the same house are positive for COVID-19. One develops symptoms, say 4 days after the other. When can they cease isolation?
Yeah, great. So it's a combination therefore of being both a case and a close contact. So great that we've now got kind of empirical guidelines for people who are at home, being managed at home. So just to reinforce the group that they apply to, they need to be managed at home or have left hospital well enough to continue a period of isolation at home. That's a lot of our patients, but not all of them. And we no longer rely on the 2 negative tests in this milder group. They need to be 10 days after their onset and at least 72 hours after complete symptom resolution. So that will kick in. But you're, in addition to being a case, I guess in this scenario, you're potentially exposed to somebody who's infectious for that period of time too. And so you need to serve out a period. For example, I might refer to some of the people at home with isolated cases, doing a great job looking after that person. That person's potentially infectious right through to the time that they treated that. At the moment, it had been 2 tests now, the 10 days. They continue to serve out, if you like, a period of quarantine for another 14 days after the last time they were exposed to someone who's potentially infectious. So for some of the people who are looking after cases at home, we owe a double debt of gratitude because that's really, they're looking at an extended period of time.
Thanks, Tony. All right, we might move on to case study 2. Oh, I think this has dropped out.
We do have another technique.
Oh no. Sorry, Tony, do you mind just clicking over?
Yeah, it's actually...
You just got a virus.
That's not...
Oh, beautiful. Okay. Oh, yes, we're working. Lovely. So this case study is probably not quite as rosy, but worth talking through some of the implications for general practice, and there have been questions on the Slido about what does it mean if a staff member develops COVID-19. So this was a scenario that's actually been adapted from something that happened. So this isn't exactly as it happened, but we've just tweaked it for some educational purposes. So our hypothetical is that we had a practice staff member who was a household contact of a confirmed case, however did not know that their household member was confirmed until sometime down the track due to testing, delays, etc. They did have some mild symptoms on, say, the 17th of March, and they did go to work the next day for an hour, and then they received a phone call saying, your household contact is a confirmed case. So obviously that person was sent straight home because as a close contact of a confirmed case, they needed to be under now the 14-day quarantine. But I would also argue that this person, due to their onset of mild symptoms and being in a healthcare setting, being a healthcare worker, should really have been at home since they developed symptoms. So really emphasising the importance of staying home if you're a symptomatic healthcare worker. So subsequently, it did evolve as I don't think I've put that in there. So subsequently, the person was tested and did come back some days later as positive for COVID-19. And so there was quite a bit of contact tracing that needed to happen yesterday, over the weekend. And so contact tracing, just to again go through what the criteria that we use in risk assessing healthcare worker contacts. So we're talking about face-to-face, so for example consulting a patient directly or having a conversation face-to-face with a person for more than 15 minutes, and this may be also cumulatively more than 15 minutes, so 10 minutes here, 10 minutes there, and not wearing any personal protective equipment. And then also that criteria about the same kind of larger indoor space of more than 2 hours not wearing any PPE. So this would be, if you had, say, a reception staff that was working, anyone that had been in the waiting room for that long, or, another reception staff that was sitting further away than face-to-face but had been there for a whole day, for example, that would be considered a close contact. Just to highlight that this was quite a large amount of work that was done by the practice manager of the concerned practice. So they said that they were on the phone from 9:30 a.m. until 7 p.m. So just highlighting that in the event of this kind of scenario, it's worth thinking about surge staff and putting somebody that's just dedicated to work on this, at least for the day, to identify all of the staff and patients that have potentially come into contact. So the good news was that no patients fell into that definition of close contact. The bad news was that 3 doctors and 2 nurses were assessed as being close contacts of this person from the 1 hour that they worked whilst they were symptomatic. And that resulted in 5 of the staff of this not particularly large practice now being quarantined for 14 days. So that is a substantial impact on practices. This might sort of close down a small practice altogether. So I think, the key messages from here are, first of all, don't go to work if symptomatic, and I will stress that this is hypothetical, so I'm not saying that anything was done wrong in the actual scenario. But if you are a healthcare worker, please do the right thing and stay home and consult somebody for advice about whether or not to be tested for COVID-19. And then I suppose the second thing is that it is a graduated approach to risk assessing. So just because there has been a case in the practice, even if that case is a staff member, it doesn't necessarily mean that everybody that's been in the practice needs to quarantine. And it also doesn't mean that all the patients necessarily are close contacts. So public health does help you with those risk assessments. As the case numbers swell, then this is something that we see general practices increasingly taking the lead on as part of sort of a workplace health and safety obligation. So that's our second case study. Do you have any other thoughts on that one, Tony?
Well, just to, I guess, emphasise that, not coming to work. So I think you've made that case personally and professionally here. But it's kind of putting into practice what we say each winter, but we practice imperfectly. And so I think we just need to give the people around us permission to really put that into practice at the slightest kind of onset of respiratory symptoms, and reinforce that. It's now part of our team meetings at work each morning. We check in on each other and make sure that nobody has even the slightest start of symptoms. And of course people aren't going to come, but it's part of the culture of just really making it expected and okay for people not to come to work. If that's the case. So I think that's actually a really big shift that we all need to get really good at.
So a question that gets asked of me is rhinorrhea, just an isolated runny nose that people get from time to time, might have a bit of sinus or something like that.
What do you say, John?
Well, I think pharyngitis, definitely yes, cough or shortness of breath, those are sort of mainstream symptoms, and certainly the aches and pains and fevers, the flu-like syndrome. Isolated rhinorrhea, I've always got a question about. You have to check through other symptoms, and I guess if you're in doubt whether you're developing something, then probably staying at home even with isolated rhinorrhea, because tomorrow you might have the sore throat or something more significant. So I think it's taking that level of caution. We had a staff member recently who had very minor symptoms who subsequently developed a fever, and then the penny dropped and she had a test and was positive. But would have been nice if the penny dropped earlier. So it's not always easy to judge, and I think, as you say, having a third party check in on you so that you don't have to self-diagnose and worry about it. So,
But I think certainly, isolating on symptoms, but then testing, maybe delaying that.
Certainly delaying until something significant. I think testing very minor symptoms. I came back from Papua New Guinea just I think the week before I did the second one of these. Yes. I had a runny nose, but which was a bit out of ordinary. So I consulted a colleague and had a test. It was negative, and it didn't develop into anything, but just got me thinking.
Good practice. So I think it is a kind of culture shift for us all this winter. Good practice, and making it easy for other people to do the right thing. And I guess the other point I'd make, Kat, and I know we've rearranged times and so forth here just to make it sort of most useful for this discussion, is that this is going to be a real challenge for staffing the practice, but the practice doesn't need to close down because of a COVID patient through the room, and presumably over the next 6 months, every practice is going to have people come through with COVID infection potentially. So just the presence of someone with COVID when they're infectious does not mean the practice needs to close. So simple cleaning and rooms that people have been in can be used again after a wipe down of surfaces, unless there's been some aerosolising kind of procedure, which is a cue just to say, let's not use nebulisers in practice. There's been a couple of times when we know that nebuliser use is potentially aerosolising, and so the use of a nebuliser with someone with COVID infection does introduce that whole aerosolisation kind of issue. So it's something for us all to get sensitised to, and certainly for people who need bronchodilators, there's almost always good response to spacers and metered dose inhalers. Clearly there's a nebuliser still used for some other client groups, but jump in, John.
Yes, there are quite nice studies with radioactive tracer showing that a nebuliser delivers most of the dose to the oropharynx, and it gets systemically absorbed, and that's why you get such a systemic reaction to nebulised Ventolin and other things, salbutamol. whereas a spacer, the deposition occurs within the spacer and the inhaled portion goes into the lung.
Yep.
So you get much more effective delivery of it into the lung. I don't know if there are questions about children there, Kat, are there? Or?
There's more questions about pregnancy and other risk features. So
I was going to mention children because that's been exercising people's imagination around asthma and croup and bronchiolitis. Bronchiolitis perhaps is a bit of a grey zone, but certainly croup and asthma doesn't seem, in children, hasn't been associated with this virus at all. And so we think it's, and children as a group are rarely getting severe infection. So in large Chinese series, it's only 2 or 3 children that have required intensive care, for instance. So the testing criteria currently, we are testing children who come in with any acute respiratory illness because we have to know for protection of staff, but we don't believe that we'll find a lot in admitted patients. It'll be the other viruses causing that bother.
Sorry to put you on the spot like this, John, but just coming back to the question of trying to, I suppose, if we do have symptomatic healthcare workers or if we are symptomatic ourselves, whether there are sort of processes to expedite testing in healthcare workers?
So they are just setting up a parallel testing clinic for healthcare workers at John Hunter to get them out of the test line for the fever clinic. And I think staff are going to be prioritised for local testing, but I don't know for sure. I guess that's a good point. Sometimes it'll make a difference if you call the particular pathology company and say that this test is high priority, particularly if there's a lot of things are riding on it.
But I suppose if you are wanting the test to be done in Newcastle and have the quicker turnaround, then it would need to go through a public clinic, wouldn't it?
Yes, I think so. None of the private pathology companies are doing it on site, I think. It all gets sent to Sydney, for sure.
Great. All right.
Yeah.
Well, I think that's all for our content. So we've got about 45 minutes left for questions. We'll just take a quick little break. Did you need some water or anything, Jane?
I might top up actually.
Yep.
Yeah, let's do that.
But just while we've got this little ad break, we might just give Community Health Pathways a plug. So this resource has expanded substantially over the past week and is now divided into different sections. Am I going to put Sandra on the spot to speak? Or, no, okay, I'll tell you about it.
I'm sure if you would like to, but would you like me to?
Yeah, but do you want to have a quick word about what's on there now?
Yeah,
Sure, Sandra.
Hi. Sorry, I wasn't dressed for a webinar. So we've now got a suite of 5 different pages. We've got the assessment and management pathway, which is statewide for New South Wales. And then we've got a referral page, which has got information around private pathology providers, which we update pretty much daily, as well as the public clinics, the screening clinics. And then we've got an information page which has got links to various things like how to get the masks, and we will add the hand sanitizer that I've just heard about tonight. And then there's also a practice preparation page which goes through infection control and caring for patients within the practice and so on. And we are about to start an impact on local services page, so you can go there to find out what's happening in your local public hospitals in terms of changes to services to outpatients, to presenting to emergency and so forth. Yes, and just on the hydroxychloroquine, we tonight are adding a whole medication drop-down box which is going to have things like that, and ibuprofen and all the things, ARBs and ACE inhibitors, all those things that people have been asking about. Okay. So yes, moving feast. And we have linked to the CDNA guidelines on outbreaks in aged care facilities.
Great.
Thank you.
Thanks, Anne.
Wonderful. Okay, so in terms of our approach, there's a lot of 118 questions, and we've sort of addressed some through the presentation, but we will, as we did last time, commit to trying to answer everything, if not here, then in a written format. So I will just maybe start from the top because we've got a few upvotes up there, and then we'll try and group them a little bit. So the top suggestion or question is from Dr. Jim Stacey. How do you suggest GP clinics run flu vax clinics for over 65-year-olds? My idea was a drive-through clinic like an RBT at a quiet street area and inject through the window. So really innovative suggestion there. I don't know if anyone on the panel wants to comment on that. Infection control.
I'm sure you can orchestrate that safely, and I guess there's going to be quite a bit of anxiety about older people coming into a practice, potentially exposing themselves because they're listening to the messages out there. What do you think, Tony?
Oh, look, I love the idea that this will spawn a great deal of innovation. You know, the idea of drive-through swabbing at Belmont, of very innovative practice solutions. I think we should encourage that.
And I wonder, whether the PHN, for example, might be able to. Obviously, there's some quite active GP forums like Hunter General Practice Association, but maybe whether there could be some sort of a centralised discussion board for specifically COVID-19 content for people to share their experiences and ideas.
Thanks, Kat. That's a really good suggestion and one we've been looking at. We're looking at a number of mechanisms for that, and we hope at least this week to have some information out about forums for GPs to be able to discuss and share ideas around this. So we'll get some information out in one of the bulletins this week.
That's great.
Watch this space. So yeah, I think that's a great idea. Other suggestions I've heard about from some other people have been, having specific clinic days that are just for doing things like children's immunisations, or so really trying to cohort your well/routine care away from the potentially infectious. And there are a number of mechanisms for doing that. So I think that's a great initiative. What do we do when GP clinics run out of PPE so that we remain operational and are not overwhelming the emergency departments? And we've spoken a bit to conservation, but John, do you have any thoughts around that?
Well, goodness. So I guess without PPE, you won't be able to safely do procedures. You potentially can have brief consultations with patients. You can have consultations with patients that don't have respiratory illness, of course. But you have to confine yourself away from doing things that are going to, give a risk to the healthcare provider, for sure.
So in terms of masks, we have access to the national stockpile, which is, if you like, quarantine for primary care at this point in time. The national stockpile is being replenished as a matter of urgency from both local and international sources. So masks are something that we can assist with. I've talked earlier about a local supply of hand sanitizer. What we don't have access to at the moment is eye protection or gowns. And we've certainly raised that with the Commonwealth and continue to put pressure on them to try to address that. The issue is retooling local manufacturing to be able to address that because of the issue of international freight movement at the moment.
So eye protection, certainly if you wear glasses, you should go into your OPSM or NIB and get some wraparound. That's what I have. I should have brought mine along. Prescription specs. Bunnings still has some goggles that go over existing eyeglasses. Someone picked those up yesterday. And I don't think there's too much of a shortage in the hospitals for eye protection, but yes. Gloves, I don't believe gloves are in short supply. Gowns, yes.
Okay. And this is a great question. The next one, can health professionals still go to work if our home contacts have upper respiratory tract symptoms, but no COVID risk factors of travel or contacts, if we ourselves are well? Tony?
Looking at me. So I guess we've talked if somebody at home had COVID, which is not your scenario, I appreciate, and you're a close contact of a confirmed case, then you're in home quarantine for that period of time. So there might be people who find themselves in that situation. But in the event that you are a perfectly healthy contact of someone who's got some respiratory symptoms, then on the whole there's no restriction there. If for some reason you had people had a very high level of suspicion that person was developing COVID, I guess there's room for discussion with the public health unit team there, but the straightforward answer is no, except in sort of extenuating circumstances. Yeah.
Yes, perhaps the person's talking about their snivelly child, something like that, or infant. And I guess there we could be reassured by the Chinese experience where children were not found to be a significant part of their transmission chain. Certainly children are getting asymptomatic infection frequently, but they don't seem to be key in transmission chains, perhaps because their viral load is not very high or for whatever reason. And I think if you've got a symptomatic child, it probably is a different virus to this one.
Yep.
So it's probably a protective factor.
And I suppose the other thing that we can take some comfort in is that the general consensus is that COVID-19 is not infectious sort of longer than 24, or certainly at the very most 48 hours prior to the onset of symptoms. And so it's unlikely that people who are asymptomatic would be going around transmitting it unknowingly for a substantial period of time. So really just adhering to, trying to exclude on first symptom as a healthcare worker, I think is the responsible approach.
And that's where the social distancing is of value.
Yes, yes. Okay, so I think we've spoken about that. So management of healthcare workers with viral symptoms not reaching threshold for testing, so case by case. We've talked about general practices where a staff member tests positive. There's a comment about RMS driver medical assessments to be granted a 6-month amnesty, and I think certainly the government will have to be.
Yeah, look, I saw that question and I'm happy to take that up through the relevant authorities in New South Wales. Yeah.
Thank you. Maybe this one for you, John. Can you get COVID-19 coronavirus more than once?
Yes, well, we had our Nobel laureate telling us about that. He's not convinced that there's evidence. I think this virus particularly hasn't been mutating at a great rate. It's an RNA virus. It will mutate and change its spots and escape immune response, no doubt. Maybe next winter we might face a different strain that is slightly modified, like happens with flu. I think there's no evidence of good evidence of second infections that I've seen.
And John, any evidence around what we can expect in terms of immunity in people who've been infected?
Well, we know that immune sera has a neutralising effect in cell culture, so that it can prevent the virus from infecting the cells in a cell culture. So that's usually a good sign that at least our antibody level immunity is protective. There's cell-mediated immunity as well. You'd probably have to ask an immunologist that there are over 1,800 papers now published on COVID-19. I haven't read them all, so.
No, and look, I haven't, it was perhaps an unfair question without notice, but I haven't come across anything with compelling evidence that, I guess my sense there from what I've seen is that we just don't know, and there's no guarantee. I heard a great plan, I'm sure many of you have, of young people going and getting themselves infected and travelling to Europe while the flights were cheap before they stopped completely. And we just simply don't know about what level of immunity there'll be and for how long it'll last.
Just on the subject of sera, John,
yes.
There is a question just in terms of the utilisation of serology. Can you comment briefly on that?
Yes, so there have been some point-of-care serology tests that have performed well, looking for IgG and IgM at 7-day mark, and the majority of those are positive. There are serological tests available now from Westmead Hospital, so if you've got a patient that you're really trying to backtrack on to work out if they did have COVID-19 and they're outside that positive PCR window, you can request that test. Those tests are being used in the school research studies as well.
Yep, so probably more relevant for epidemiological and research
Probably,
purposes
yes.
at this stage.
Yeah.
But yes, it is available. So we did discuss how long surgical masks can last before needing to be replaced. There's a question about keeping a P2 mask on for a duration.
Yes, so again, P2 or N95 masks do retain their efficacy even though they can get moist. So you can go on wearing those for extended periods of time.
They're pretty uncomfortable though to wear for a prolonged duration.
Yes, because if they're put on properly and fit checked, they're quite confining, and yes, people don't find them very pleasant, and some of them sort of rub on the nose as well.
Okay, there's a comment about keen to know if there's anything being done to get GPs ready to care for corona cases and likely end-of-life care in the community. So I think we have spoken to the home management of cases, and certainly other options are being explored. I think there was a comment further down in terms of actual isolation centres for confirmed cases. So that work is happening at a district level. In terms of the end-of-life spectrum, I don't...
So as part of the aged care workforce, the aged care response, we are inviting palliative care to participate in that. And encouraging the discussion around advanced care directives, particularly for those individuals who currently do not have one. So that's an ongoing discussion, and the aged care workforce group will make some recommendations around that.
Thanks, John. Okay, another one for John Ferguson. What general advice to the healthcare workers, GPs, staff returning home after a day's work to their families in terms of general care, clothes, shoes, etc.?
Oh, okay. Well, look, I'd assume that your clothes are probably contaminated from working through the day. It's not just the external contamination, but our body flora prints through our clothing as well. So it's a good idea to change out of your gear and have a shower. It's a good way of shedding the worries of the day as well. Get into that routine, and clothes can then be hot washed, and that's all that's really required. Then you can start interacting with your family. That sort of just, I think it's probably a good routine. In the hospitals, we're looking more widespread use of scrubs. I've always thought we should be changing into scrubs when we get to the hospital and leaving them at the hospital to be commercially laundered. And that's certainly the model they follow in Northern Europe. You go into hospital wards, they're like operating theatres. Everybody's in scrubs. So perhaps that's the way ahead for us. I think wearing clothes that are practical, that don't have long sleeves, is a good idea. Avoiding wristwatches, complex rings, just so that we can keep our hands clean. Obviously having our hands in good nick, no artificial nails, etc.
Thanks for that, John. I think there was also a question sort of on that note in terms of management, maybe this is more a question for Tony, in terms of management of sort of social isolation within the home.
It's a real challenge, isn't it? So let's say you've got a not uncommon scenario with one person who's just got mild confirmed COVID infection, and they might have a partner and 2 children, and they're well enough to be managed at home, and the family is well placed to deal with that. And so there is a real challenge there, and you touched on some of these points. I'll summarise it again, Kat. What we ask of those people is that they separate themselves very much within the home. So ideally the person who's got confirmed infection would have their own bedroom and bathroom as much as that is humanly possible, and that's very often the circumstances these days in the houses of people we've been talking to so far, at least. And that the rest of the household are in separate rooms using a separate bathroom. So that achieves that kind of overnight separation. It achieves the separation of surfaces which can be readily contaminated in bathrooms. And then the challenge is, what about the occasional shared space? And as you mentioned earlier, what we ask is people in this situation wear surgical masks if they're in a shared space. So keep that to a minimum. Obviously that would be ideal, but surgical masks on people who are sharing a space. And attention, again, as you noted earlier, to repeated, simple cleaning of surfaces to make sure that there's no contamination there. So transmission really is droplet spread close up and through surfaces onto hands and then transferred to the face. And so cleaning surfaces and washing hands regularly obviously breaks that chain.
Mm. And I think one scenario that we're coming across increasingly, and I don't know that there's an easy answer to this, is, for example, if you have, say, a mother and a father and 2 children in a household, and say the mother becomes a COVID positive case, sure, the others in the household can be isolated from her, but should they be isolated from one another? Because we have experienced some scenarios where, say, the father has then gone on to develop disease, and then there's been other chains of transmission that have prolonged the time course within that household. Because technically those other 3 people are close contacts and should be isolating from other people generally, including each other. So it's a really tricky scenario, and we've seen this play out on some of the cruise ships that we've spoken about. It's not good enough just to put everyone who's not affected currently under 14 days necessarily. So as I said, I don't know that there's an easy answer, but if it is possible at all, then it's ideal for those people who are close contacts to also be separated from each other in case they go on to become cases themselves.
And it's good, just a reminder of the point we made earlier about it not being inevitable at all that household level contacts with infectious cases become infected. It's entirely possible to live through that experience and not become infected.
There's another question here which is getting some upvotes, and I don't know that we can answer it today, but requesting some comment around the use of spirometry in general practice.
Okay. Yes, so there are some experts up at John Hunter who've schooled me on this. I think there are particular mouthpieces that have antiviral filters that prevent the spirometer. Depends a bit on the type of spirometer you've got. So, look, I think probably take that offline, and you should talk to John Brannan and John Harrington at John Hunter, because they'll give you chapter and verse on different sorts of spirometers.
The National Asthma Council have some guidance around it too.
One of the things is the peak flow meters can be they're personalised and they're easy for the as a substitute. They don't give you the full lung volumes, but they're certainly able to determine control of asthma, measures for control of asthma adequately over a period of days to months. So that's probably the way to go to avoid spirometry at the moment.
With the concern being around aerosolisation?
Well, you'll create an aerosol, you'll potentially create a foam out of the machine, which may not be easy to clean. It depends on the sort of machine though, and your infection control around that machine,
Okay. And as I mentioned, John, there were quite a few questions in terms of pregnancy as a potential risk factor, or also people with potential risk factors being in the health workforce at this time.
Yes. Look, we don't believe pregnant women are at excessive morbidity risk, but the counsel is for them not to be caring for COVID-19 patients. So we're not expecting them to do that in the health system. I guess there've been small case series of pregnant women who had COVID-19 and have all done very well. I don't think
no
there's been any
association with increased risk of miscarriage or anything?
No,
like that?
I don't think so.
No, I haven't seen anything like that either, and nor a strong story about vertical transmission.
No.
So it's, which is quite different to. So I think there were concerns around SARS and MERS in relation to that. So that sounds like an encouraging story today.
To the question of people with other risk factors like diabetes or immunosuppression continuing to work in this current climate, John Bailey, you might want to comment on this, but I understand just today new telehealth item numbers have been announced.
Yeah, so the federal minister today announced some new telehealth item changes, and they include changes for the practitioner, whereas the previous criteria related to the patient. So the new changes, health professionals who are currently authorised to use telehealth item numbers and to use telehealth for all consultations with all of their patients include any practitioner who's over the age of 70 or at least 70 years of age, Indigenous and aged over the age of 50, pregnant, the parent of a child under 12 months, and immunocompromised practitioners, or have a chronic medical condition that results in increased risk from coronavirus infection. So those announcements were made today, and will update the advice that we've been giving around telehealth. I can also draw to your attention that we're looking at as much as possible enabling telehealth from a small grants perspective, and general practices have been contacted to let us know what it is they think they need and how we can assist them enable telehealth.
Thanks, John. That's great. And I think also, if there is any possibility of people, if they're in maybe administrative roles like practice management or something, if there is a capacity for them to be working remotely or, working from home, then they're all legitimate options that should be considered at this stage. Okay, so I think there's a couple of public health related questions. So are people who are looking after COVID patients at home allowed out to source food?
So they are in quarantine. Yeah. So and again, it goes to the point I've mentioned a few times about the extraordinary ask that is going on here. So we're asking people who are quarantined at home by virtue of recent travel or contact with confirmed cases to stay home. And so we recognise it's a huge ask, and that means coming up with innovative ways of getting food supplies to the house. So through delivery services or friends and contacts, then that's what we're asking people to do, literally, if you're isolated or quarantined, to stay at home. It's great if you've got a yard or a space there or a balcony that you can get out in, but the request is that you not share public spaces with other people, but we recognise that's enormous.
Mm. There's another curly question about somebody who's under quarantine, so asymptomatic, and whether they're able to go outdoors to exercise or take their dog for a walk if they won't encounter any other people.
What do you think, Ken?
I think it's a great question, and I suppose it's potentially a slippery slope. So, logically that would be, I suppose, acceptable. However, given that there's a lot of potentially uncontrollable factors in terms of who you might come across, even at Glenrock or something like that. I don't know that we could really advise that is.
It is tricky, yeah. And the formal, when people in quarantine read through their New South Wales Health Fact Sheet, it really does ask them not to be in public spaces, and so.
You could probably go for a long drive in your car with the windows up. But no, great question.
You guys are tough.
That's the recommendation anyway.
Yeah.
Okay, so I think we've gone through most of the questions. Oh, there's a great question here. I have a patient with acute respiratory symptoms who works at a correctional facility. Is this a high-risk situation, and should COVID testing be done?
Yes, well, the first bit is easy. There's no question we've seen big correctional facility outbreaks internationally, and it's it's a high-risk population just by due of the way people are accommodated, and it's certainly occupying people's minds within the correctional services. It's the number of accommodation units where they are shared with more than one person, so there really is potential for outbreaks which will be really challenging in aged care. In the correctional services. Yep. So again, I think it fits into that kind of clinical acumen and suspicion around what might be really significant illness in a particular setting.
So we're very keen to pick up on respiratory outbreaks in aged care, but do we have proactive monitoring of prison populations for respiratory outbreaks, per se?
Not that we get involved in, John, because they're kind of a separate unit unto themselves. So not that I'm familiar with, but there is a Justice Health unit, and I know this kind of considering what an appropriate preventative and response mechanisms will look like is something that they're actively exercising their minds right now.
And we're not aware of any current problems.
I haven't heard of that being a setting that's active in Australia at the moment.
Okay, I think, as I said, there's a lot of questions coming thick and fast, but I think that's covered the majority of topics. So unless there's anything else from people.
I've had a question from several GPs today.
Yes.
One of the pathology collection companies is doing self-swabbing.
Yes. Yeah,
what are your thoughts on
sorry, this was
self-swabbing?
one on Slido. So question about self-swabbing and whether that is legitimate. I'll say anecdotally, I know one of our cases, so positive cases did do that. So I don't know, John, do you have any thoughts on that?
Look, generally when self-swabbing techniques have been brought in by pathology, they have to validate them and show that they are an adequate sample compared to, so for instance, women collect samples for HPV testing or STD testing, and it's been quite validated in good studies. I don't think there's been any validation information with self-swabbing that I know of. So I'd be a bit dubious about why you even do it unless it was a research setting.
And I suppose the risk is that you might have a false negative if it's inadequately collected.
Yeah. And look, arguably the nose and throat sample is probably 75% sensitive in early illness, so it's not perfect anyway. So, and that's highly reliant on getting a good specimen in.
Yeah, I think we can come up with different innovative solutions like drive-through swabbing with people trained to take good samples. I would much rather see us heading in that direction than self-swabbing with everything that we know at the moment. Yeah.
It seems to be that saliva has a high viral load in a lot of people, so that might be a suitable sample. They just spit in the tube after their breathalyzer.
So John, over the weekend I read an article that talked about the fecal.
Oh yes, so that's another option. The virus is excreted in the stool in a majority, so certainly in hospital when we have high suspicion of a clinical case, that will be a secondary specimen site that we'll go after. Yeah, it's a good point.
Okay. There is one last question. We'll finish on cruise ships. Do I quarantine domestic-only cruises? Do we quarantine domestic-only cruises?
Do you know, I think this is, there's an easy answer, but it's got a longer history. So, I mean, our request that people self-quarantine on return has been flagged by kind of international exposure and is marked by being on international soil. And what's become really clear that the cruise ships are essentially intermingling of lots of international people. So it is international exposure, with the exception of tiny, boat trips with an audience out, a small group out of Port Stephens or something. But a trip from Fremantle to Melbourne or Newcastle will, I think, certainly have people who've flown internationally, and so that's the experience we've had. And cruise ships have obviously just absolutely exploded as an issue in the last couple of weeks, but have been there in the background. And they're an environment that has delivered richly in terms of respiratory outbreaks in the past. Gastrointestinal outbreaks. And they're doing that absolutely at the moment for COVID. So I think, so the short answer is yes, but it's that kind of growing understanding about exactly what's been going on and the experience, particularly the last 2 weeks. Yeah.
Yes, I think they're an environment that are very difficult to clean and disinfect. Lots of soft furnishings, so it's incredibly difficult to eradicate pathogens. So we've had that trouble with norovirus on cruise ships, particularly. There's so much environmental contamination, and getting rid of it all to prevent further cases has been a big issue.
Do we understand why the Italian experience is so problematic in terms of the rapid climb and the almost vertical situation? What's different about Italy? Why are we seeing what we're seeing there?
I'm happy to have an initial stab, and then I think the sobering point is that their trajectory is not dramatically different to the one that lots of countries are on, with doubling every kind of 3 to 4 days, and they've continued. So the question is that's the virus in populations wherever they are around the planet. What can we do to kind of impact that? So that's yet to play out in Australia. In South Korea, they've changed the course of their outbreak with really intensive testing and good old-fashioned public health. The kind of isolation quarantine that we've been really reinforcing is such a critical thing for us all to contribute to. That has been completely massive effort on their behalf. Look, it got away on Italy, and I don't have enough detailed knowledge to comment too much, but it's the point we were making earlier. If you're going to intervene, you really need to do it as early as you can for lots of reasons. You want to get on top of things early, of course, but also we're dealing with dated information. Like what we know about now is at best half the real situation here. And when you intervene, you need to do it comprehensively and firmly. That's the hammer of the dance, if you like. And clearly there were some examples early on in the Italian experience where the social distancing wasn't rigorously applied. But I don't know if either of you'd like to comment further about that.
Well, there is one northern Italian village that took a South Korean approach.
Yeah,
and screened every member of the community and found, I think, 4 or 5% of them had relatively asymptomatic infection, and those people were quarantined. And that had an amazing impact because those people, often young adults, minimally symptomatic, were serving as a reservoir, obviously. And that's in Korea. They've gone after a similar population and found a large number of 20 to 29-year-olds that were carrying the virus, I think, that were tested even though they were asymptomatic. So,
And it kind of, I'm just inviting you to keep talking about that.
It's just interesting to have that experiment take place in Italy.
Yes.
As Tony says, that they're on the same trajectory, a bit further in advance of the UK, for instance. The UK is probably 2 weeks behind Italy in terms of its case numbers and deaths. I think the death rate is particularly high in Italy because the health service is overwhelmed, and also the elderly population, the proportion of elderly is very high.
And John, that age group, I guess, the 20 to 29-year-olds is kind of underlines the targeted social distancing measures today. There's a lot of talk about schools, which we can engage with potentially if we want, but clearly in terms of having an impact on that age group, it's going to be non-judgmentally bars and restaurants and gathering places and perhaps even public speeches.
They're immortal. They don't think it's going to hit them, but they're key to control, as you say. I think that's shown by the Korean and this Italian village experience.
Yep.
We can say there's no millennials in the room, are there?
Might just be a few amongst those watching. That's right. Be careful.
Right, well, on that note, I think that's been a great discussion, and it's difficult to gauge reactions, but there's been really lovely engagement on Slido. As I said, we will go through the list in more detail and try and address ones that we haven't, or escalate ones that we can't answer to the appropriate channels. So I just want to thank you all again. Obviously it's been a very tiring last few weeks. And so again, just reiterate the message about, look after yourselves and look after each other. And as healthcare workers, do the right things in protecting your communities.
Thanks, Kate. Nicely done, and thanks everybody for being part of this tonight.
Do the Slido feedback.
Oh yes, please complete your Slido evaluations. We do read it, and we do try to tailor these sessions to be better in future.
Yeah, but the written comments actually really helpful. So it's nice knowing overall, but it's that kind of detailed feedback, and it's changed the format over time, and I think we imagine there might be more of these if that's useful. So please, just a little bit of time on those comments is actually, we read every one of those, so thank you.
So in terms of future events, we will be guided by the panel here and the changing circumstances. As we are given advice that it's warranted, we will redo these sorts of events at points in time in the future where we're able to do that, where the advice has changed, or where we think there is an important issue to communicate.
Thanks everyone.
That's a wrap. Thanks, Ken.
Thank you.
Good night.